Hi, this is Kimberly. Please enjoy our podcast, but remember our doctors are only here to educate, not diagnose. If you have any questions or need any further information, please email me. My email address is kim@mfwellness.org.
Happy summer, crawling in here. It seems like every Wednesday that we're going to do a podcast, we crawl in here half dead after seeing patients all morning, and we try to remember what the heck the topic was. That was nuts today. Good job, you guys.
Yeah.
Giving us some good care. Yeah, you're right. We're all on the same page with how good of a job we did.
Kim, how good of a good job did we have?
Kim, do you have anything to add to the group?
Great job, guys.
I feel like that was coerced.
Yeah.
It was.
Kim, the audience really likes listening to you. I've heard from more than one person.
Oh, really?
They're like, oh, is that Kim? I'm like, that's Kim over there. You know?
I'll talk more.
Listen, you got to break free from those chains.
Did you write that down, Kim? She doesn't know who that is. She doesn't know. You don't know about Wilson Phillips, do you?
No.
Sometimes there are days when.
All right. Okay. He's getting ready to do it. He's going to do the thing. Okay. So this week we want to talk about vertigo. One of our patients asked us to speak about it. Like 6 weeks ago, we said we'd get it in, and now we're getting it in. So vertigo. I mean, that's about as fast as we can do it. So vertigo, in layperson's terms, it's just a sensation of being off balance or being dizzy. And there's two ways, when people say, oh, I have vertigo, we'll immediately say to them, hey, are you spinning or is the room spinning? Because it helps us identify the different types of vertigo. So WebMD or your classic medical literature lists really three kinds of vertigo. There is BPPV, which is far and away the most common diagnosis. Like fibromyalgia, it's just the diagnosis they slap on you when there isn't enough testing or when something is poorly defined, like, oh, it must be fibromyalgia. Anyway.
What does that stand for?
Benign paroxysmal positional vertigo, Kim. And
that's what we're going to call it.
It's super cool, yeah. That's why nobody ever says it again. It's thought to have to do with the little stones in your ears not being positioned correctly, or maybe one of them breaks loose, or the mechanism for you being able to tell what direction you're facing or being able to turn your head quickly, because there's little bitty rocks in your ear canals. And those little bitty rocks, those tiny things called canoliths, their positioning is slightly magnetic, and it allows you to keep your balance left to right and in quick side-to-side motion. Sometimes they get dislodged, and people can get that. So there's different cures for it or different ways to treat it. Another kind is what they call Menieres disease. And again, this is another trashy one. And we have, through the years, had 4 billion people in here that say they've been diagnosed with Menieres disease. And so Menieres disease is actually an inner ear disorder. So it has nothing to do with the actual stones. It's the neurology behind inner ear transmission. It's thought to have symptoms of vertigo and ringing in the ears. So those two are often together. So we get to see that in this facility a whole lot. That we have throughout the year. So, and then the last one is actually vestibular neuritis or labyrinthitis, and that's actually an inner ear lining infection, either from a bacterial or a viral, and that's the one that we see the least, I would think.
I think I can remember one offhand where they came in, they had other signs and symptoms, like they had a fever and stuff. And I was like, I think you better go.
Yeah, you gotta get this checked out. Yeah, that's the one thing. Fever is just its own deal. 90% of your diagnosis is going to be in the history and consultation. And man, fever just puts a red flag on so much. And that's definitely one of them. It's like, I had a fever and my ear hurts. Okay, well now we're going to check it out. So, and then the reason why we care so much about vertigo and we care about dizziness is because it leads to that often linked symptom that leads to stroke. So like, oh, I'm dizzy. From this going on, and they talk about upper cervical arterial impingement or stroke, and saying that phrase in this office is going to get you a good, firm, 45-minute long talking to, at least 45 minutes, complete with case references and a really, really, really firm dissertation. We're not going to go into that now because we have a whole podcast we've devoted to that. So. One thing that you'll know, something that sets off vertigo, is when you change your head rapidly. It's like the world can't catch up with you. So that's what vertigo is. I was going to go through some case studies about chiropractic and vertigo, and I'm like, well, let me just pull one from 2021. Well, there's 117 case studies that have been published on vertigo 2021 chiropractic offices. I'm like, okay, let me just go in this last month. Well, in the month of June, there were 17. So everybody's publishing case studies on vertigo because we fix it all the time. And it comes from a couple different things. One, it could be that there are malpositions, subluxations of C1 on the occiput, causing impingement. It's thought to cause impingement and disassociation between the conductive hearing and sensory neural hearing, which causes that dizziness. There's also what they call Eppley's maneuver for restoring it. Now, I know when you guys are going to talk about that. So
Yeah.
my objective was only to identify what vertigo is, and talk about a chiropractic case study, but there are so many, it would just be impossible. Suffice to say, we treat it in chiropractic offices, or we treat it in this office during the summer and during the winter, like the hottest parts of the summer, and then the coldest parts of the winters when we see it the most.
What about patients that are taking medicines that?
Oh, yeah.
That
Absolutely.
that
I didn't even think about that.
Yeah.
I didn't even think about that. Of course, there's
3 or 4 of them that
that's a
specifically
known
say,
side
hey,
effect.
Yeah.
Yeah.
It's a known
The
side
known
effect.
side effect is
Yeah.
vertigo?
Yeah.
Ugh.
Yeah.
Wow.
Yeah, that's on there. It's small print. The other thing is you go like WebMD and it's like treatment for vertigo. They talk about different medications to counter the medications that you're already on. And then they talk about vestibular rehabilitation, which is physical therapy. But the one thing they don't talk about, chiropractic care, even though it's proven super, super, super safe, proven to be effective. And so it's like, well, we compete with them. And so they don't mention us. But it's like, they took an oath. You can't publish this. You can't leave that out. You are now denying patients information. Like that just drives me crazy. Like they'll take any shot they can at the profession. But man, when you start asking them about it, well, we don't know. Oh, we don't know if that's proven. Like it's just okay. I'm just gonna let it go because I'm on the verge. When Kim starts leaning back away from me, I know it's time to really hand off. All right, Dr. Maurer.
Yeah, so what I was going to talk about is treatments for vertigo outside of, these aren't all outside of what we could do in our office, but these are less chiropractic. And I'm going to let Dr. Matt speak specifically on chiropractic treatment for vertigo.
Chiropractically yours.
So the first one, it's kind of been mentioned, is the repositioning maneuvers. And this is for those BPPV.
Nice.
Those calcium deposits, or sometimes you call them crystals, that are located in the canal. And there's 4 major ones: Eppley, Samant, Foster, and then Brant Daroff. And I have helped, and Kim, you were there.
Yeah.
I helped a patient get through the Eppley. Actually, she came back twice.
Mm-hmm.
She felt really great, started to come back. We did the second time, and then it was clear. So
That's so cool. Like, what a cool.
It was such a cool
yeah.
experience.
And it is something
it's
that
neat, isn't it? Like
Yeah.
when somebody's like wrecked and then you help.
and
That's
then just
cool.
immediate, yeah.
Yeah, as soon as she set up, she was
like,
like, oh my god, I can do this now. And then she came back, and I think during the test, it started coming back a little bit, like the vertigo. So
and
you
I
had to
redid
rework it,
Yeah,
yeah.
I redid it.
That's
And then
cool.
after that, she was good to go. So it's pretty neat. And what you do, you could even do that Eppley on your own.
Yeah, you can find it
It's
online.
just certain situations, but I helped her through it, and you can see the eyes darting back and forth as you move the head different ways. And once those eyes stop darting, that's what I was doing, helping to see when that happened. And then once that happened, we moved it back into the other position. So basically what you're doing is you're moving those deposits into an area of your ear where they can actually be reabsorbed potentially. So that's a big part of that. And that's why potentially if once you get them away, they may not come back, or it may be a while before those deposits form again. So that's the repositioning maneuvers. I know you just mentioned the vestibular rehabilitation.
Yeah.
So if it's something
I
that's
stole your stuff. I'm sorry.
you're fine. If it's something that's been around a while, your medical physician may say, hey, you need some vestibular rehabilitation. And that's to try to strengthen that vestibular system to be able to handle you having vertigo. So that's something we would necessarily do.
Can I ask a maybe dumb question? What is vestibular mean?
The vestibular apparatus, it's the generic term that doctors use to describe our ability to translate sound and vision into a positional sense. So you can see and you can hear, and that tells you where you are in space. So there are 4 quadrillion things that affect the vestibular apparatus. And so to be specific, we can talk about cerebellar nucleus, little dense pools of neurons in the cerebellum that coordinate all that information. But when we say vestibular, we're referring to primarily your sense of balance, but indirectly your sense of position. Does that make sense?
Yeah, it does.
Yeah.
And usually a physical therapist would be the one to perform them with.
Yeah.
Gotcha.
Yeah. And they do a good job. Like you know what I mean? Like,
I much prefer that over
oh yeah.
the things that I'm going to talk about next.
Oh.
Medicine, which you already brought up.
Yeah.
So, and sometimes it's just to help with the nausea. You know, maybe just something they give you to help with the nausea or the motion sickness that you're having. You mentioned the illness. So if they do find out you're dealing with a bacterial, antibiotics, and maybe even steroids to bring down any type of inflammation that might be occurring within the ear. And then you mentioned the Menieres.
Mm-hmm.
So what they may give is a diuretic, basically to reduce pressure fluid buildup.
That's right.
So the only thing I've come into an issue with is that I come in, you know, someone comes in, you do your history, and you really believe it's a BPPV, but they're taking medication that's
This
not
is a side
for those
effect.
purposes.
Yeah.
So yeah. And then the last thing on here is surgery. So, you know, hopefully that's the
Yeah.
last.
What kind of
last
surgery
option.
would that be?
Well,
Oh.
In some cases, let's say it may be needed. Like if they find that you have a tumor, and that's
causing it.
Yeah.
Or if you've had a severe brain or neck injury,
Right.
that maybe need surgery for that. But once again, we're talking about neck again. Neck involved. Dr. Matt's going to talk about what we can do as far as
Gotcha.
that goes and how the neck relates to that area.
yeah, so chiropractically speaking, we look at C1 and C2 almost exclusively, and we look at how C1 is fit underneath the occiput. So when we do the adjustments for vertigo, we do almost straight lateral to medial adjustments through C1.
Right.
And the reason why we do that, because if we try to turn the patient's head, guess what?
Puke City.
Puke City. And so...
Ride all of your new khakis, Kim.
Yeah. So...
Your new khakis.
That's why we don't wear new khakis here, because you're going to get puked on.
And
At
while
least 10 years
while
old.
we're doing that adjustment, we talk to the patients. Okay, where can you go at from here? Can we turn your head a little bit? And then you just work the portion of that back in through the therapy, and you just keep going more and more and
It's
more.
very slow, very intense, and a lot of watching the patient. You know, there's a lot of physical diagnosing that goes into it, and I think we really shine at it. Chiropractors in general, but of course us specific.
Of course.
So the other thing that we do is we adjust the ears. We make sure that those eustachian tubes are freely moving. They don't get clogged up.
Nice.
So, like we were talking with Dr. Josh and Dr. Brad, if there's a backup and it's not draining properly, you're going to get fluid buildup in that side. That is that's going to throw off your sense of balance and put you more at risk of developing vertigo. Usually when we see vertigo cases come in here, it's either an existing patient or it's a brand new, I've had this, whatever, I can't sit up. My friend's bringing me in. You will find that the 4 or 5 of them come together. So like it's never just like one case a week. It's 4 or 5 cases that kind of pile on one another and we all see them the same day. It's just something that happens, and we don't know if it's like just in the air or what. But so chiropractically speaking, C1, C2 is what we check. We can also work with, if they can't lay down, which is a big thing, we can adjust them seated. Now, if you know chiropractic, Gonstead adjustment through the occiput and C1 is just a seated normal adjustment through P to A, and that's just basically
Back to front.
Yeah, back to front.
Back to front, Kim. Her eyes are still glazed over. She doesn't know where you're at, Dr. Fink. Gonstead is there are different types of adjusting. Right?
Okay.
Diversified, activator,
yeah.
okay. Gonstead is one of those, and it is an extremely specific adjustment. One adjustment, one spot, and we call it line of drive, the way you're going to push the bone. So you push your hands towards me, or you push your hand up at an angle to me, or you push your hand sideways to me. Those things affect it. And so when you want to get really specific listings of vertebra, they talk about how one vertebra relates to another in a very specific way and how they're going to correct that.
Huh.
It's super, super cool stuff.
So along with adjusting that way, following up and corrective care regarding vertigo is cervical traction. Phase 1 and phase 2 that we do here at the office.
And not like the traction with people growing up where they hook a sandbag to a door and you're on the other side of it. That's what, when you say traction, that's what people think of. Because they used to hook them to a door. And that's how they would pull. The people would fight the sandbag and they just tear
Some
them.
people still do that. Like,
Yeah, and that's not, I'm sure there's some clinical cases, but I can't imagine what they would be. So what you just need is a fulcrum and the person to relax rather than fighting the sandbag the whole time. It's ridiculous.
So we talk about postural awareness and being able to get up every 28 to 30 minutes, checking your posture, making sure that there is no chance for your neck to go too far forward and get you into a bad position. Right. So chiropractic speaking, that's how we treat vertigo here.
Cool.
It's cool. So one other thing is like what Dr. Matt said about the specific adjusting that we call line of drive. Like that's what chiropractic is. That's why we get so crazy when people say manipulation. Like manipulation, it doesn't matter what the relationships of the bones are. You're going to manipulate them. You're going to get them to move no matter what. Mm-hmm. That's crap. That's not specific. Like you don't know if you're getting the problem, you're just getting the whole area. Anybody can do that. You throw you down the stairs, you're going to get manipulated. Adjusting is the specific analysis, detection, removal, and then recheck of an area. That's what makes it so great. You know, it's not some global blow up the bones action. It's a specific response to an analysis. That's what makes us doctors. I get crazy. It just drives me nuts when I just in general hear that not talked about. You know what I mean? Like, in this study they manipulated a blah blah blah. We didn't think it was very effective. Like, okay, that's because you're just racking bones around. You know, like anyway. So okay, that's vertigo. It's now been covered. One other thing, you know, why we see it so often, more often in the summer during the hot months. My thought, gentlemen, is that you're outside. It's hot. You're like, oh, going crazy. You know, it's summer in St. Louis, 6 trillion% humidity, 100 degrees. You come inside, you're hot as can be. You lay under a fan on high, or a ceiling fan's on, rapidly cool off, right? The carotid artery, which is pumping blood to your brain, is underneath one very long, powerful, super cool muscle that we call the sternocleidomastoid, which takes its origin from the skull and it hooks all the way down, partially onto the clavicle and partially onto the sternum. And I think what's happening is that the air that's circulating is rapidly cooling that muscle, even though you have warm blood running behind it, and that inevitably leads to muscle contracture, unscheduled muscle contracture that we call spasm in the business.
Sounds like a research project.
I know. So then the SCM spasms, and because it's hooked onto the 11th cranial nerve, starts feeding that crazy information into the brain. You can't turn your head, and it sets off the whole vestibular apparatus. That's what I think is going on. That's why we see so many of these cases right now.
Dr. Matt keeps his SCMs warm.
Dr. Matt protects his SCMs with a fine beard. The rest of us should start wearing SCM guards.
Perfect.
It's funny.
That wouldn't help.
My part was serious though, Kim. But he does have a really great SCM covering beard.
Yeah, he does.
Okay. Kim, do you have anything for the people?
No, I don't.
Dr. Maurer?
That last bit was it. That's all I had.
It's because Matt's over there stroking his beard. Nobody can focus right now. Dr. Fink, anything for the people?
I do not have anything for the people.
Okay. Man, we've got an awesome summer full of really cool podcasts coming up. Kimberly has been working so hard to follow up with patient requests. If you have any requests, please, 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 Kim, K-I-M, at mfwellness.org. We've really enjoyed bringing these in response to patients, and we really take our obligation to educate pretty seriously. So if you have anything you want us to talk about, we'll talk about it till you throw up, but not 1 second longer. All right. So for Kimberly, for Dr. Matt, for Dr. Brad, I'm Dr. Joshua Fink, and we will talk to you in 2 weeks. Bye.
And a big thank you goes out to Hug Monster Sound for somehow allowing the doctors' voices to sound even better than they already do.